Thank you for joining me today. I'm Joseph Owen, and in this screencast, we're going to discuss our imaging toolkit and talk about the different modalities, their indications, their costs, and their strengths and weaknesses. At the end of this screencast, you should be able to describe the different indications, costs, strengths, and weaknesses of the different modalities. Why is it important to get the right modality for the patient? Well, you want to match your modality or the diagnostic imaging that you order to a specific clinical question, and that often starts with formulating a good clinical indication. Factors that are going to go into which modality you select or which imaging you order includes the accuracy for the suspected condition, specific patient factors like allergies to contrast, the presence of metal or medical devices, the ability of the patient to cooperate with the exam, the amount of radiation that they're going to be exposed to, and the risk-benefit ratio of the potential to make a diagnosis versus the small risk of radiation, and then often cost and availability play a big factor. So today we're going to talk about X-ray, CT, MRI, ultrasound, and nuclear medicine. Starting with X-rays, right? This is one of our most basic imaging modalities, and I've listed some common indications for X-ray here. So in terms of musculoskeletal imaging, looking at fractures, dislocation, types of arthritis, and different types of bone tumors, X-rays can be very useful. In the chest, we're often looking for pneumonia or airspace disease. We can detect pneumothorax. We can look at heart failure and detect pulmonary nodules. Very common to do chest X-ray for those different indications. In the abdomen, it's a little less clear why you should use an abdominal radiograph. I really think it's best used for lines and tubes, but in some cases, it can be helpful with bowel obstruction, detecting free air, or looking at foreign bodies. And in this case, I would include lines and tubes under foreign bodies. In breast imaging, mammography is sort of the cornerstone of breast imaging, and we're going to use a type of X-ray for both screening mammography and for diagnostic mammography. Screening when the patient's asymptomatic, diagnostic mammography when there's already been an abnormality detected, or there's some sort of pain or palpable lump. The strengths of radiographs are that they're widely available, very accessible, and in many indications can be read by the person ordering the study, or at least previewed by the person ordering the study. They are relatively inexpensive, they're very quick to take, and in general, they give you really nice contrast between bone and gas and soft tissue. But because they are a 2D modality, they are somewhat limited. The weakness of X-rays is that they use ionizing radiation, although modern X-ray radiation dose is very low. Another issue is that they have pretty poor soft tissue contrast, so differentiating muscle from subcutaneous fat, differentiating ligaments, you can't really do that with an X-ray. And because the X-ray is a 2D modality, all of your different structures will be superimposed on each other, and this can obscure abnormalities. And so X-rays are somewhat limited when you're trying to assess complex anatomy. Overall, their relative cost is very low compared to the other imaging modalities that we'll talk about, on the order of $100 plus or minus. Computed tomography, or CT imaging, is a detailed cross-sectional imaging modality. So it provides good detail, and it is sort of a 3D assessment, right? Some indications for that, trauma, we use CT all the time in trauma, whether it's head, neck, chest, spine, pelvis, right? We use it a lot for cancer detection and for staging and follow-up of known cancers. It's very good for vascular imaging, and in most cases, we refer to it as CT angiography or CTA imaging, and we'll use that for suspected pulmonary emboli or aortic pathology in the setting of stroke, assessing the neck and head vessels. It can be very good for complex infections such as abscesses, and it's the cornerstone of imaging for acute abdominal pain. We also use CT as a guidance tool when we're trying to biopsy something or place drains, decompress the chest, decompress the collecting system of the kidneys. Its strength is its excellent anatomic detail, and that anatomic detail is provided in cross-section. It's very fast to acquire. It only takes a few seconds to get a whole body CT, and therefore it's very good for emergencies, unlike something like MRI, which may take half an hour to an hour to acquire. It gives us very good differentiation of bone, soft tissue, and vascular structures, especially when we're using intravenous contrast. It's widely available. Most hospitals and outpatient centers are going to have a CT scanner, and it is also a relatively easy to interpret modality, meaning most board-certified radiologists are going to feel comfortable interpreting most types of CT examinations. One of its main weaknesses is its higher radiation dose. So it's much higher dose compared to X-ray, on the exponentially higher, orders of 10 to 100 magnitude higher radiation dose. Another disadvantage is that to get a really good CT, in most instances, you do need intravenous contrast, and so that's going to require an IV, and it's also going to require you to be aware of the patient's renal function. It's more expensive than X-ray, probably tenfold more expensive, and it's more expensive than ultrasound, probably twice, 3 times as expensive as ultrasound, but it is still less expensive than MRI. One issue that we commonly encounter is artifact from metal. So whether that's an implanted medical device like a pump or a nerve stimulator or a prosthetic joint such as a hip, those can cause a lot of artifact and degrade our image quality. So overall, its relative cost is moderate to high, so certainly substantially higher than X-ray or ultrasound. Magnetic resonance imaging, or MRI, provides us with superior soft tissue contrast. So even within a single tissue type, we can see subtle differences within that tissue that can be very revealing. Indications for MRI would include brain tumors, strokes, multiple sclerosis, infections in the brain. For musculoskeletal imaging, soft tissue injuries can be well delineated on MRI. Abnormalities of the joint, abnormalities of the bone marrow and cartilage. In the abdomen and pelvis, MRI can really excel with characterizing certain types of liver tumors or liver lesions. It can give a detailed evaluation of the biliary tree. It's excellent for the female pelvic organs and is good for prostate cancer as well. And then we also have certain tools within MRI that allow us to do vascular imaging without contrast. So in some patients who cannot receive contrast, whether that's iodinated CT contrast or gadolinium-based MR contrast, we can do non-contrast techniques to assess the vessels. In terms of the strengths and weaknesses of MRI, again, excellent soft tissue contrast. We have no ionizing radiation like we have with CT or X-rays. We can image in multiple different planes. And in some specialty MRIs, we can actually get some physiologic information, such as detecting stroke through diffusion restriction or characterizing an abscess versus a simple fluid collection, or looking at the perfusion of the brain. Some of its weaknesses include the length of time it takes to acquire the study and the need for patient cooperation. So patients are going to be placed in a long tube that's very narrow in a high magnetic field, and the patients are going to have to lay very still, often on their back. If they move or can't cooperate with breath holds, the image quality is often compromised. It's very expensive compared to X-ray, ultrasound, and CT. And certain patients will have contraindications. So certain metallic implants that will react within the magnetic field cannot be imaged. So certain types of pacemakers, particularly older models, older aneurysm clips, foreign bodies, especially near vital structures like the eye or in the brain, bullet fragments, those kinds of things can be a contraindication. There is some risk to gadolinium IV contrast. That's particularly thought of in patients with renal impairment, but that is less of a concern with modern agents. And there is some concern for deposition of gadolinium in patients who receive numerous MRIs or repeat MRIs due to follow-up imaging or routine imaging. It can be a little less sensitive to acute hemorrhage, particularly subarachnoid hemorrhage, and so a CT of the brain or head can outperform MRI for detection of subtle hemorrhage. And one of its big weaknesses is its lack of availability. So not every hospital is going to have an MRI. Not every radiologist is going to be comfortable interpreting all of the different advanced MRI imaging that can be performed. Ultrasound imaging, or sonography, is a real-time imaging modality that is radiation-free. And when I say real-time, that just means that there is a person in the room acquiring the images and looking at the images in real time. Some indications for ultrasound include a wide variety of indications within OBGYN, so fetal assessment, pelvic pain, assessing the ovaries, looking for fibroids. It's good in the abdomen for very specific indications like detecting gallstones or cholecystitis, screening the liver for abnormalities, looking at the kidneys for hydronephrosis, or determining whether a nodule on a kidney is a simple cyst. And in kids and pregnant patients, then adults, we can use it for the appendix. It's very good for vascular imaging, so we can detect flow with ultrasound, we can characterize the direction of the flow, the velocity of the flow, and we can look at the shape of the pulses, and that can often give us good information determining stenosis, cardiac function, occlusion, blood clots, etc. With musculoskeletal imaging, it's often a targeted type of imaging where we can assess certain tendons or ligaments, we can look for effusions in the joints, and we can characterize soft tissue masses. We also use it a lot to look at the thyroid. It's the best modality really for thyroid nodules, and we use it a lot for scrotal ultrasound assessing the testicles for abnormalities. Because it is a real-time imaging modality, it's also really good for procedures, so we use it a lot for biopsies, line placement, aspiration, and that in that instance, often the person performing the procedure is using the ultrasound in real time to guide their needle or their wire. Strengths: no ionizing radiation, real-time imaging allowing dynamic assessment. Another advantage is that it's portable, so you can take it to the ICU, you can take it out into the field in Africa, right? It is really good at differentiating something that's cystic from solid, and it's great for looking at blood flow. One of the big weaknesses is that it is operator dependent, and it's limited by patient body habitus. So the larger the patient, the lower quality the ultrasound will be. Ultrasound cannot penetrate bone or air, and so that does limit our ability to assess bones and joints, the lung, or the bowel. And often the field of view is relatively limited. In terms of its cost, it's sort of a low to moderate cost, more expensive than X-ray, but cheaper than CT. Nuclear medicine and PET is a type of sort of functional imaging or a molecular imaging. So in this case, instead of shooting radiation through the patient like we do with X-rays or CT, we typically administer some form of radioactive particle that particle is often bound to some biologically active substance. So it may be an antibody or a protein ligand or a sugar. And the body will then accumulate the radioactive particle attached to the ligand into specific cell types or tissue types or areas of the body. And then we put detectors around the person and try to map where the radioactivity is most concentrated. When we think about indications, general nuclear medicine, we do bone scans looking for metastasis or infection. We do thyroid scans looking to see if there's excess function, no function, detect pulmonary nodules. We can look for pulmonary emboli through ventilation perfusion scans. We can look at the gallbladder function and how it contracts. And we can look at the renal system, how it takes up and then excretes certain nuclear particles. With PET, PET is often done in conjunction with a CT. And so in this case, the most common one is FDG PET. That's a radioactive particle attached to a sugar. And what happens is you give them that radioactive sugar, and the more metabolic areas of the body will take up that sugar and concentrate it in areas of high metabolic activity, such as the brain or specifically tumors. So this is often used for cancer staging. It can be used for assessing treatment response. There are modern PET agents that help with assessing the brain for signs of dementia. And it's also very good at assessing the myocardium and how viable the myocardium is, particularly after a myocardial infarction. So what are some of its strengths? Well, its strengths are that it provides some degree of functional and physiological information. So it's not just looking at the underlying anatomy, but it's actually mapping metabolic function or certain cell types to the underlying anatomy. And so we can, in certain instances, detect things at an earlier stage than just imaging alone. And we often are able to image the whole body. Weaknesses, it uses ionizing radiation. Oftentimes, it's a higher dose of ionizing radiation than CT. We typically have sort of poor anatomical detail on PET imaging. It's not as good as MRI or as a high-quality contrast-enhanced CT. Another drawback is that it's very expensive. Okay, so most nuclear medicine studies are kind of moderately expensive, but PET-CT is one of the most expensive imaging studies you can order. And it has limited availability. It requires very special facilities, not only to conduct the imaging, but to handle the radioactive substances that are given to the patient. In conclusion, there's really no best single modality. The choice is going to be dependent on the clinical context. You want to develop a good clinical indication based on your patient's presentation and your differential diagnosis. Consider referencing an appropriate use criteria resource. Consult with your radiologist if you still are unsure of what to order. And when you place your order, think about the implications of a positive or negative study. Always place an order intentionally, knowing what you will do with the information if that study is positive or negative. By understanding those modalities, we can hopefully be better stewards of our imaging resources and improve the care of our patients. I thank you for your time, and I hope you found this useful, and I hope you reach out and look at some of the other screencasts available. Thank you.